Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Rogel University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And today we are continuing on our colorectal cancer journey, this time talking to one of our awesome clinical pharmacist colleagues. This is Allison Schepers, who's a PharmD from University of Michigan. I love our pharmacy episodes because, as we know, so much of the work that we do is related to the medications that we give patients. And as always, it's so insightful to hear from our pharmacy colleagues how they counsel their patients, how they think about the drugs that we give our patients. I'm so excited, again, for our listeners to listen to this guest episode.
We've said this every episode that we have this in our podcast, that the pharmacists are so important for the care of our patients. We would be totally lost without them. I mean, these patients would not get appropriate chemotherapy without our pharmacists. So really excited to learn from the guests we have on today and excited for all of our listeners to hear this one.
And, particularly in such a highly curable disease, I love hearing from the pharmacy perspective because we need to know how to counsel our patients on toxicities, how to think about dose adjustments when we're still shooting for cure. It's going to be a great discussion.
And I do want to give a special shout out to our friends at the Pharmacy Podcast Network who have been awesome in supporting the Fellow on Call for a while now, but they also have a wealth of knowledge on their platform. And I encourage anybody interested in learning more about pharmacology and new drugs and therapies to check out their platform as well. So without further ado, let's go ahead and roll that show. Guys, we have another fantastic episode today, and everyone knows we love our episodes where we have our clinical pharmacists joining us. And today is no exception. We have Dr. Allison Schepers, who's a clinical pharmacist specialist at the Rogel Cancer Center at the University of Michigan. And she's also the residency program director for the PGY2 Oncology program, an adjunct clinical assistant professor at the College of Pharmacy. And her clinical focus is on GI, GU, and thoracic malignancies. So we are in the middle of our colorectal cancer series. We can't wait to pick her brain about GI cancers. Allison, thank you so much for being here this evening.
It's my pleasure. Thanks so much for the invitation.
As I said, we learned so much from these episodes, and you guys are such critical components to the care team for our patients. And so I'm so excited to hear your thoughts about some of the things that we have planned. But we always like to start these episodes with asking our guests to tell them one fact about ourselves. So what is one fact that you like to share with people about yourself?
That's a good one. I would say my most interesting fact was a celebrity encounter. So when I was 21, I actually met Josh Groban on my birthday, and he sang me happy birthday.
That's insane. Where did this happen? Tell us more.
So I'm from Grand Rapids, Michigan, but he did a concert there, and I went with my mom and my sister, and they had a mechanism where audience members could submit questions. And my sister submitted, like, will you come and sing my sister a happy birthday? And he did. So my sister has given me a gift I can never repay.
It's amazing.
That's incredible. Oh my gosh. I mean, I don't think anything that we're going to talk about on this show today is going to top that experience, but we will try. I'm happy to kick things off for you. One of the backbones of treatment for colorectal cancer that we've been talking about in our show already so far is 5-fluorouracil or 5-FU and the prodrug, the oral version, the prodrug version, capecitabine. So first, talking about 5-FU, could you briefly comment on the push towards infusional 5-FU over bolus 5-FU? These are terms that get thrown around as we're talking about management all the time, but people don't always define them. And is there a difference when it comes to side effect profiles between infusional and bolus 5-FU?
Yeah, of course. The earliest 5-FU regimens that were used back in the 80s and 90s were all bolus regimens. So if you ever hear the terms thrown around like the Roswell Park regimen or the Mayo Clinic regimen, these were bolus 5-FU regimens. So people got a bolus dose of 5-FU either every day or say once a week. But these regimens were actually pretty hard to tolerate and had a lot of side effects. So people had lots of myelosuppression, mucositis, diarrhea that really limited the ability of people to complete adjuvant therapy for colorectal cancer with bolus 5-FU. And when I say bolus, that's administered over a short time, so like 15 minutes or 1 to 2 hours. So around the late 90s and early 2000s, we started moving towards continuous infusion 5-FU regimens. So the early ones had doses administered over 22 hours times 2 days, or like in our current state, you probably are familiar with continuous infusions over 46 hours. These continuous infusion regimens were much better tolerated, lower rates of mucositis and diarrhea, as well as hematologic toxicity, and also proved to be more efficacious than the bolus only regimens. So, kind of in current state, probably people are familiar with like a modified FOLFOX6 type regimen where we use both the bolus 400 mg per meter squared as well as a continuous infusion of 2400 mg per meter squared over 46 hours.
That makes sense. Thinking about extending the time under the curve, trying to get people to a greater degree of efficacy. And also thinking about extending that time under the curve, I want to talk a little bit about capecitabine. A lot of people assume that because it's a pill, it's going to be like less intense than IV chemotherapy. But in my experience in fellowship, that was not the case necessarily. Can you talk a little bit about how you counsel patients on the side effects of 5-FU versus capecitabine? My understanding is capecitabine is just the prodrug of 5-FU. Are there some side effects that seem to be more common with one or the other, despite them being essentially the same drug?
Yeah, definitely. So you're exactly right that capecitabine is an oral prodrug of 5-FU. It does have some similarities and toxicities, but definitely some differences. So we do see much less hematologic toxicity with capecitabine than we do with infusional 5-FU. And most of that hematologic toxicity with 5-FU is due to the bolus dose. But capecitabine has its own suite of side effects. So we see much more hand-foot syndrome with capecitabine. We also see higher incidences of diarrhea and some more higher grades of mucositis. It also seems like some people really struggle with nausea with capecitabine, and just especially capecitabine you have to take for 14 or so days compared to the 5-FU continuous infusion, which is much shorter in duration. So sometimes that nausea and GI side effects can really be more burdensome to deal with the capecitabine. So yeah, less heme toxicity, but kind of more of everything else.
And you mentioned hand-foot syndrome. When do you expect that to crop up if it's going to? Is it like a deeper into deeper cycles you tend to see it more, or can it be present sort of from the get-go?
Yeah, it can be present from the get-go. It usually takes about a week or so to develop, so it's not something that's going to happen when people take their first dose, but can certainly happen during the first cycle or the first few weeks of treatment. There's some, I think, important kind of counseling points or prophylactic measures that might be helpful for people to know about. At a minimum, people on capecitabine should be administering a non-scented moisturizing lotion at least 2 times a day while they're on capecitabine. Some people prefer to use a urea-based moisturizer. That's also effective for preventing hand-foot syndrome. And then recently there was data presented on the use of Voltaren gel twice a day to prevent capecitabine-induced hand-foot syndrome. So that's kind of our newest tool to help prevent hand-foot syndrome. From a kind of non-pharmacologic perspective, I always just tell people they need to be really gentle with their hands and their feet. So avoiding heat and avoiding friction. So like no scalding hot showers. If you're like doing dishes and hot soapy water, make sure you're wearing some sort of glove. Make sure you're wearing well-fitting shoes and socks. The worst case of hand-foot syndrome I ever saw was a younger patient who wasn't kind of thinking and played like pickup basketball barefoot on a concrete court. So just like really being careful about things that are going to be rough on your hands and your feet. If people do experience any sort of hand-foot syndrome, often we'll use topical corticosteroids to help treat that. We often use like triamcinolone 0.1%. You can use a higher potency steroid if they have any like specific lesions or areas that are really irritated, potentially holding drug if needed.
One of the things that I think will be really helpful for our listeners, and there's no right answer on how to do this, but let's say you have a patient, they got hand foot, or maybe they're having issues with diarrhea. How do you think about dose reductions of capecitabine?
Yeah, so I think kind of once the acute toxicity has resolved, I often think about dose reduction in terms of frankly, just logistics of like how many pills are they taking. So it's often not like a percentage, but right, if they're taking 4 pills in the morning and 4 pills in the evening, you go down to like 3 and 3. So I think it's all about like what's making it easy for the patient. Capecitabine comes in 500 milligram tablets and 150 milligram tablets. We try as hard as we can to just keep people on one tablet strength, so 500 milligrams. So often just bumping down by 1 to 2 tablets per day can be helpful.
One of the things that I remember learning about in fellowship when it comes to going back to 5FU was the phenomenon of coronary vasospasm. And of course, that's very scary because in theory, you can't tell the difference between someone having a true myocardial event versus this being vasospasm. They need to undergo essentially the same workup to make sure it's not a true coronary event. And so this can be challenging for our patients. I'm curious, number one, do we ever re-challenge patients that maybe are getting a great response to 5FU therapy if we think that they had developed a coronary vasospasm? And similarly, have we ever seen anything like this, or can we see stuff like this with capecitabine?
Yeah, so great question. We do re-challenge with 5FU, even if people are experiencing coronary vasospasm. Obviously, it's, dependent on the degree of symptoms and kind of the safety of re-challenge, but we have re-challenged before. 5FU is a backbone agent for most GI cancers, so we hate to take it off the table completely. But typically, if we're thinking about re-challenge, that usually entails pre-medication with oral medications like long-acting nitrates, like isosorbide, as well as a calcium channel blocker. We typically use diltiazem. You start those medications 24 to 48 hours before your 5FU is planned to start. You continue those medications throughout the 5FU infusion and for about 48 hours after. The coronary vasospasm is thought to be related to kind of continued exposure to 5FU over time. So it can occur with capecitabine. Switching to capecitabine is not typically an effective strategy for managing coronary vasospasm. We usually keep people on the continuous infusion 5FU. If it's a patient who we're really worried about or kind of a little nervous about re-challenging, or the patient is nervous, sometimes we've admitted them for, inpatient 5FU for 46 hours just for that kind of first re-challenge cycle to make sure everything goes well and resources are available if needed. But we have successfully re-challenged with those cardiac medications.
Thinking about the sort of worst case scenario when we really get a lot of intense side effects from 5FU, I've heard that there is a drug that can sort of reverse some of its effects, uridine triacetate. When is this actually indicated? Like, when would you reach for an antidote to 5FU/capecitabine?
Yeah, so I love talking about uridine triacetate. So it is an antidote. So it should be used either in settings of kind of catastrophic overdose or severe early toxicities. And I'll start with kind of the catastrophic overdose because that one's the much easier one to identify and manage. So catastrophic overdose would be like situations of pump malfunction, right? So instead of delivering the dose over 46 hours, the pump delivers the dose over 1 hour. People whose 46-hour infusion finishes a couple hours early, that is not a situation you would reach for uridine triacetate. But like catastrophic pump malfunction, right? Somehow a dosing error made it to the patient and they got way more 5FU than they were supposed to. Or unfortunately, there have been reports of self-harm attempts by people taking their whole bottle of capecitabine at once. So kind of those overdose situations are kind of the slam dunk indication for uridine triacetate. As soon as you realize there was an overdose, you should start uridine triacetate. You do not wait for symptoms to appear. You should start the uridine triacetate as soon as you can after the overdose. With uridine triacetate, it competes with 5FU for incorporation into RNA. So the sooner you can get uridine triacetate going, the more effective it's going to be. And that's why there's kind of a caveat with uridine triacetate that you have to start it within 96 hours of 5FU or capecitabine administration. So if it's after the 96-hour mark, unfortunately, the damage is probably already done and uridine triacetate is going to be less effective. The course is a 5-day course. So it's an oral antidote that's given every 6 hours for 5 days. So a total of 20 doses. So once people start it, they should continue the whole course. So yeah, if an overdose ever happens, that's kind of a clear indication to start uridine triacetate. The trickier situation is those early onset severe toxicities. And that can be tricky because a lot of times toxicities don't appear within 96 hours. A lot of toxicities take longer. So by the time patients realize they're having them and call in, it's often past that 96-hour mark. But if someone is experiencing severe diarrhea, severe mucositis with their first exposure to 5-FU or capecitabine, that would be a reason to think about giving uridine triacetate. Again, if they've received like 8 cycles already of 5-FU based therapy, they're probably not going to need uridine triacetate, because this would typically probably be to an undiagnosed DPYD deficiency that we didn't know about. So you would expect it to present with their first exposure. If you do catch a toxicity early, you can start uridine triacetate, but I think it's important to realize that the studies that got uridine triacetate approved, the vast majority of people were overdose. There were very few of these early toxicity patients, and those early toxicity patients, half of them required mechanical ventilation along with uridine triacetate. So uridine triacetate is not a magic bullet for these early toxicity patients. In my opinion, they should be admitted to the hospital. They're going to need more additional supportive care besides uridine triacetate.
That was super helpful. And probably, every medical oncology fellow, every oncologist needs to know about it, because this does happen. I mean, it's going to happen to you at some point. And oftentimes, like you said, it's like a pump malfunction or something happens. And it's important for us to recognize this. And that was really good. I didn't know all of that about having the deficiency, and maybe that it wasn't really studied as well in that setting, and that those patients do require hospitalization. So let's move on to the next drug and all of our regimens, oxaliplatin. The thing that we talked a lot about in our episodes about 3 months versus 6 months, and really just this neuropathy, right? Neuropathy is the biggest concern for our patients. Just wanted to get a sense from you as a pharmacist, when we think about oxaliplatin neuropathy, how should we be counseling our patients in terms of this acute and chronic, and in terms of duration and repeated doses of oxaliplatin and recovery?
Yeah, definitely. So oxaliplatin is unique among chemotherapy agents in that it has these 2 pretty distinct types of neuropathy. So the first is the acute cold sensitivity, and then the second is the kind of more traditional chronic peripheral neuropathy. So I tell everyone that they will get the cold sensitivity. It's expected, it's normal, it will happen. That usually happens anytime starting after the oxaliplatin infusion is done. It typically peaks around the 2 to 3 day mark and then resolves within the next few days. So it doesn't last the entire cycle. People have described it as like feeling a lot of throat and esophageal pain if they drink or eat cold foods. Someone described it to me as like knives going down their esophagus. People feel pain if they like reach into a freezer, or like living in Michigan, people tend to get kind of hit in the face if they walk out of the infusion center and it's like 0 degrees outside. So we tell people to avoid, like, don't use ice in your beverages for a couple of days. Don't eat super cold foods. If you need to reach into the freezer, like put an oven mitt or a glove on or something. If you're coming in the winter, like bundle up, bring like a hat and a scarf with you. That should self-resolve after a few days. It can be a little bit cumulative. So we do have people who are like, each cycle it might last like an extra day, or it's a little bit more severe. But this is really like a kind of self-limiting phenomenon. It is not, something that is at all permanent. And there's really not a lot we can do to prevent or treat it other than like those kind of cold avoidance strategies. And it's the only chemotherapy that causes this. The other neuropathy is kind of your typical peripheral neuropathy that is cumulative and tends to worsen as people get more oxaliplatin. It usually can start to interfere with activities of daily living around cumulative oxaliplatin doses in the ballpark of 800 mg per meter squared. So people getting like 12 doses of FOLFOX will be kind of at that number by the end of their treatment. So again, this is close monitoring to make sure that if people are having fine motor deficiencies, can't button the buttons on their shirt, can't fasten their jewelry, are having difficulty with like balance and walking, that would definitely be a point to consider at least dose reduction, if not holding oxaliplatin altogether. This neuropathy does have a tail, so it typically can get worse for up to 3 months after stopping oxaliplatin, and then starts to resolve over the next months to years. We've tried a lot of things to prevent chemo-induced peripheral neuropathy, various like electrolyte infusions or supplements, and unfortunately, none of those seem to be particularly effective and are not endorsed as standard of care. If people do get peripheral neuropathy that's painful, things like duloxetine or gabapentin can be considered. Oxaliplatin is kind of interesting. A lot of people will use like the ice gloves or like the ice socks or like chew ice chips to try and prevent that peripheral neuropathy. It's kind of controversial whether you should do that for oxaliplatin because that could theoretically worsen the cold neuropathy. We do have some patients who have eaten the ice chips throughout the whole oxaliplatin infusions and said it hasn't worsened their symptoms, but kind of proceed with caution with that with oxaliplatin.
That's so helpful. And a lot of our patients, especially when they're older and they're getting cancer, may already have neuropathy from like diabetes, for instance. So I'm curious, have you ever had this conversation about risk benefits of giving somebody oxaliplatin if they already have, for instance, diabetes-related neuropathy?
Yeah, so I think it's definitely kind of a case-by-case and patient-specific decision. I think if someone has pretty mild neuropathy from another condition, it's not necessarily a contraindication to oxaliplatin, as long as the patient is kind of reliable in reporting their symptoms. I think if someone is coming in with like moderate to severe neuropathy, that they really don't have any room for it to get any worse before that would like drastically impact their quality of life, then that would be a little bit of a different story.
Got it. That makes sense. Just shift gears a little bit, thinking about other drugs that we commonly use for colon cancer. I want to talk a little bit about irinotecan. How do you counsel patients about this drug in particular? I remember that I feel like GI side effects are a big thing. And I also remember something about atropine. What is that all about?
Yeah, so irinotecan, kind of the top 3 side effects I talk to people about are number 1, diarrhea, number 2, myelosuppression and hematologic toxicity, and then number 3 is nausea, vomiting. So the unique one for irinotecan is the diarrhea. Like you may have heard the mnemonic, I ran to the can. Irinotecan is prior like number 1 most diarrhea causing cytotoxic chemotherapy. And it can cause 2 different types of diarrhea. So it can cause cholinergic mediated diarrhea. That's probably why you remember atropine. Irinotecan inhibits acetylcholinesterase, so it can cause this cholinergic excess syndrome that happens while people are sitting in the chair getting infused or soon after. That might manifest as like diarrhea, cramping, even like if you think of like your sludge mnemonic, right? Like salivation, lacrimation, like sweating. So people can get any of those symptoms. And since it's a cholinergic process, atropine is going to be the best treatment for that. People can be given atropine on a PRN basis in the infusion center. That honestly is usually enough to kind of take care of those symptoms. In the future, people can also be pre-medicated with atropine prior to the infusion so that it doesn't happen again. So that's usually kind of enough to take care of that cholinergic mediated diarrhea. But irinotecan can also cause just your traditional secretory chemo-induced diarrhea that can happen, in like the first week to 10 days after the infusion. So I always tell people to like have loperamide or Imodium in their medicine cabinet at home so that if they get diarrhea, they have it on hand. People can take Imodium after every loose stool. If Imodium is not enough, like other options like Lamodal or like tincture of opium can be used. So good symptom management, making sure people are staying hydrated, et cetera. And then like one unique thing for refractory Imodium-induced diarrhea is that enzymes produced by bacteria in the gut are responsible or are involved in the metabolism of irinotecan. And actually those bacterial glucuronidases can actually convert irinotecan back into its active form. So if you have someone with refractory irinotecan diarrhea, actually oral like cephalosporins or even sometimes fluoroquinolones for a couple of days can take care of that.
With irinotecan, and this isn't really necessarily for colorectal cancer, but we have liposomal irinotecan. What are the differences in the side effect profiles between these drugs?
Yeah, so I have to be honest, we do not use a lot of liposomal irinotecan at our institution because so far the data have shown that there doesn't seem to be a huge difference in the side effect profile. Unfortunately, the rates of diarrhea, hematologic toxicity seem to be pretty similar across studies. Yeah, it's thought that maybe some of the differences between liposomal irinotecan and irinotecan may be due to like some of the 5-FU dosing and the lack of a 5-FU bolus. There are some differences kind of when you're doing cross-trial comparisons. So I wish liposomal irinotecan was better tolerated, but unfortunately, it doesn't seem to have a huge toxicity benefit compared to conventional irinotecan. But I think a good kind of take home point that like the dosing of those two agents is not the same. So it's not like a one-to-one conversion if you were going to switch someone. So just be cognizant of what irinotecan formulation you're using.
I think that's really helpful for me to know because, I always just assume that, it sounds fancy. I don't know, liposomal. Maybe it's better. I don't know. But it's kind of what I expected, that the side effect profiles wouldn't be that different, but the cost is much higher. But moving on, let's go to the VEGF inhibitors. So, our patients in the metastatic setting, we might use bevacizumab, for example, and there's a host of side effects, hypertension, delayed wound healing, a couple of those things. So I want to focus on a couple of things here. And one of those is patients with history of MI or coronary disease, things like that. How do we think about these VEGF inhibitors? Are they still safe to use? And I know that that's a very nuanced question, but from a pharmacy perspective, what are your thoughts on that?
Yeah, so it's definitely a complex question. I think the timing of the cardiac event or the myocardial infarction is important. So if you have someone who's had a cardiac event in the past 6 to 12 months, that's going to be a much stronger contraindication to VEGF therapy versus someone who's had a cardiac event multiple years ago and is kind of medically optimized and hasn't had any recurrent issues. We have used VEGF inhibitors in those patients, but someone with a recent cardiac event definitely is, I think, a little bit of a different situation. Thinking about like other kind of cardiac events, like a VTE or history of a DVT or PE is not a complete contraindication. Like being on anticoagulation is not a complete contraindication. So we've definitely treated lots of those patients with VEGF inhibitors, albeit at the risk of some sort of recurrent clot or some sort of bleeding event.
And to follow up on that, what about if they've recently had any sort of surgery or they've had a major wound or something like that? How long after that do you recommend withholding something like bevacizumab before we can give it to our patients?
Yeah, so that's also a good question. If they're having like a major surgery, right, like for our patients who might be having like their colon primary resected, that's typically going to be waiting about 8 weeks after surgery and to restart VEGF inhibitor. And that's assuming like there weren't any, wound healing complications or anything like that. It can also get complicated with some of like the VEGF TKIs, but typically you want to wait until the wound has healed almost completely before you think about restarting any VEGF inhibitor therapy. Also, something important to think about is, right, how long to hold VEGF inhibitor therapy before a surgery or a procedure. So again, making sure people realize that they can't just have like random dental procedures or like other surgeries while they're on these tyrosine kinase inhibitors. A lot of the VEGF TKIs have pretty long half-lives, so you're going to want to hold those for a decent amount of time before any procedure. So your friendly pharmacist can definitely help you with those nuances. But I think just making sure that people realize that they kind of have to have a plan if they're going to have any pre-planned procedures. Obviously, if it's an emergent situation, like that's a different story. But if we can, try to interrupt therapy for any planned procedures.
You had this big smile on your face as you gave that example. So clearly this happens more time than we probably are aware of. So that's really, really helpful to know because watch, this is probably going to come up the next time I see somebody. That's really helpful.
Yeah, definitely.
Thinking about other targeted therapies, I know that there's a role for EGFR inhibitors in management of colon cancer. So drugs like cetuximab, panitumumab, what are some of the unique side effects that we see with those agents? And is there any way to sort of mitigate risk of those side effects?
Some of the EGFR inhibitor side effects might be similar to like if you use EGFR inhibitor tyrosine kinases in lung cancer, right? So things like diarrhea, acneiform rash are going to be kind of common among all the drugs in the EGFR inhibitor class. And then I would say additional side effects that are, or an additional side effect that's unique to the EGFR inhibitors, cetuximab and panitumumab, is these can also cause a lot of magnesium wasting due to the blockade of some EGFR-dependent transporters in the renal tubules. So that's kind of a one that you might not see with other EGFR inhibitors, but you definitely need to keep an eye on with cetuximab or panitumumab. We had someone in clinic today who had received 30 grams of IV magnesium in the past week, and that brought his magnesium up to a whopping 1.3. So like the magnesium wasting, do not let it sneak up on you. Oral magnesium is often not going to be enough. So have a very low threshold to do IV magnesium repletion in these patients. Yeah, diarrhea, rash, magnesium wasting are going to be kind of the biggest ones.
One of the first times I ever actually entered our infusion center as a fellow here at Rouleau was for an anaphylactic reaction to cetuximab. I understand that there is a geographical distribution of risk for that. Why is that?
That's a really interesting story as well. So people noticed when cetuximab was first being studied in clinical trials that people in kind of the Bible Belt region of the country, so the Carolinas, Tennessee, Missouri, Arkansas, were like everyone was reacting to cetuximab, whereas people in other parts of the country it was much better tolerated. People realized that this was the same distribution as Rocky Mountain spotted fever and the same distribution as the Lone Star tick. Cetuximab contains the oligosaccharide alpha-gal, which is transmitted if people are bit or exposed to the Lone Star tick. So people in kind of that region of the country had likely had a higher chance of being exposed to a Lone Star tick at some point and had already developed IgE antibodies that then reacted when they got cetuximab. So these are reactions on the first infusion because people have already developed antibodies. Panitumumab does not have this kind of geographic reaction distribution. So I wouldn't be surprised if, centers in maybe you all's part of the country tend to use panitumumab, whereas other places might use more cetuximab. But kind of other than the reactions, I think cetuximab and panitumumab are pretty similar as far as side effects and efficacy. But yes, that's kind of an interesting trivia about cetuximab and alpha-gal and the Lone Star tick.
It's one of the things that's always thrown on a lecture slide somewhere, but it's really an interesting story. And I feel like that's a lot of what colon cancer is in the metastatic space, is just finding things out as we go through, even the left and the right side, all of these things that we found out. One thing that I think is going to be really important for our listeners to know is, what do you do if a patient gets a bad acneiform rash? What are the ways that A, prevention, and then B, how do you treat it?
There have been a couple of studies that looked at preventative strategies. So kind of the most well-known one used a multi-pronged prevention approach. So they did oral doxycycline during the whole cetuximab course. They did topical hydrocortisone once per day. People had to wear sun protection anytime they were going out in the sun, and then a topical moisturizer. And this cut the incidence of skin toxicity in half, from like about 60% to about 30%. So using some of those preventative strategies, again, at the very least, people need to be using a moisturizer and wearing sunscreen. Mileage may vary. I know like at our institution, it's kind of an even split among the GI oncologists, among who likes to prescribe doxycycline up front versus who likes to wait and maybe use doxycycline if people get a rash. But yeah, for treatment of rash, doxycycline is useful, potentially like topical corticosteroids like triamcinolone. Again, a lot of people get involvement of their scalp, so using like clobetasol shampoo is useful for that. And then potentially taking a break from cetuximab until that rash is under control.
What's really interesting is that doxycycline itself, as we know, can also increase sun sensitivity. So it seems almost counterintuitive that we use that for the treatment of this. But I think you highlighted there that there is certainly a role for things like sunscreen as well. So definitely want to be multimodal in that approach. Allison, I want to switch gears once again. And there are some other agents that some of our listeners may never see being used for some of our patients, but they may. And so I kind of want to go through a sort of 30,000 foot view of some of these drugs, just so we've at least brought these up for our listeners, and that way they've heard about them once. The first drug that I want to talk about is Lonsurf for TAS-102. And so I have heard so much about how there's concerns for myelosuppression, nausea, vomiting, diarrhea, which is truly a shame because this is one of our later line agents in the metastatic setting when patients already have a lot of symptoms. And so a lot of attendings will often recommend up titrating. What is your suggestion about how to go about doing that? Like, what is the normal routine that you typically recommend for patients as they up titrate?
Lonsurf has kind of a unique dosing schedule. So it's dosed on days 1 through 5 and 8 through 12 of a 28-day cycle. So we usually tell people that's like Monday through Friday and then Monday through Friday the following week. Kind of the package insert recommended dose is 35 mg per meter squared. and that's of the trifluridine component. So we usually kind of, if we want to start someone on full dose, we'll usually calculate like what is the 35 mg per meter squared dose and then round down to get to the appropriate tablet size for like a feasible dose. It's really important to know that Lonsurf requires CBC on day 1 and day 15 of each cycle. So that's how you're going to know if you can titrate the dose for hematologic toxicity is based on those day 1 and day 15 CBCs. Obviously, if they have other toxicities, like we see a lot of fatigue, so that might influence your dosing titration as well. So I would say like for some patients who maybe have pre-existing myelosuppression or are like very heavily pre-treated and have had issues with neutropenia in previous cycles, we might start at a lower dose. But I would say like at least at our institutional practice, like compared to regorafenib, where there is also a lot of data for starting at a lower dose of like 80 milligrams or 120 milligrams per day and kind of either staying there or titrating up, maybe it's like never tolerated. Lonsurf is maybe we have a higher percentage of patients who start at full dose, but definitely dose adjust as needed based on your neutrophil count.
Allison, one of the other really significant changes that have happened in the landscape of treating metastatic colorectal cancer is the advent of, or rather data to support the use of HER2-targeted agents. We found these mutations in patients with metastatic colorectal cancer, and so HER2 agents are an option. So we previously talked about some of these agents in our breast cancer series. In your experience, do you find there's any unique side effects that we see when they're used in the colorectal space that we should be aware of, or is the side effect profile like myelosuppression, severe GI upset, are those things pretty consistent?
Yeah, I would say for like the IV monoclonal antibodies like trastuzumab, pertuzumab, those are pretty consistent. We definitely still see diarrhea, which you probably mentioned in the breast section as well. I would say we've used trastuzumab deruxtecan for some colorectal or other gastric patients. We do tend to see a lot of, and maybe even more GI toxicity, diarrhea, nausea, vomiting, sometimes requiring like IV hydration between cycles. And I think that's probably exacerbated in our GI population just by virtue of where their disease is. So I'd say if you're using something like trastuzumab deruxtecan in GI patients, just be really vigilant about the nausea, the diarrhea with that agent.
That's a great reminder. I have learned so much today. I think you've definitely left us with a lot of really, really, really important things. And, the goal of these episodes is just for us to have better education so that when we are talking about medications with our patients, we are able to reiterate the same things that you guys are talking to the patients about. And all of this just results in better patient outcomes. Before we conclude today's episode, I just want to turn it over to you. Any final thoughts that you have for us or for our listeners?
Yeah, thanks so much for the invitation to participate. I would just say that, especially for colorectal cancer, treatment is often a marathon, not a sprint, right? We tend to like reuse a lot of our treatments over time, and we tend to use like a lot of maintenance therapies. So I would just say, don't be afraid to ask your neighborhood pharmacist for help with some of that symptom management stuff. So hopefully we can keep people on treatment for as long as possible.
I think that's the most important word of wisdom. Ask your pharmacist to tell you what to do because it happens so often and it's a team game. We say this all the time. We have these episodes. We would be nowhere with our pharmacist. So thank you so much for being on the show.
Thank you.
All right, guys. Well, I think that wraps up another fantastic episode of The Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.